Well, good morning.
Good morning.
It is a pleasure to be here. This is a statewide initiative. We've been traveling across the state, looking at our high morbidity counties, and trying to build capacity and infrastructure as it relates to screening for chlamydia and gonorrhea. This is meant to be an interactive presentation. I would encourage at any time for questions and discussion. The other thing is that at lunchtime, it's as important for you guys to network with yourselves as it is with the health department as well. So one of the reasons why lunch is being provided is so it provides an opportunity for you guys to network within the group as well with the health department as a group. So as I stated, this is a statewide initiative. We've been traveling all over the state. I'm going to be up in Erie November 5th doing the exact same presentation for the Erie County Health Department and doing stakeholders meetings there. We've been out in Allegheny, Montgomery, Chester, Delaware, and such. This is an ongoing initiative. The ball does not stop here today. This is the second presentation we've done in New York. This is an ongoing endeavor. This is the way service delivery is going to happen in the state of Pennsylvania for the foreseeable future. So a little bit about this program. Prior to year 2014, most of the chlamydia and gonorrhea screening that we were doing was in family planning and clinic-based settings. And that model worked for us, although the positivity varied between 3 and 7%. But what we were finding out is that with the Affordable Care Act and the presumption that eventually most individuals, the way that plan is working, are going to have access to insurance. What we're finding out and what we knew in public health is that just because you have access to health insurance doesn't mean you're accessing care. And the question is how do we reach those individuals that either do not have perceived risk that they're at risk for chlamydia and gonorrhea or STDs or HIV, and how do we access them and get them plugged into a larger healthcare setting? One of the initiatives with this screening is, yes, to identify those individuals that are at risk, get them treated, and get them tested. But more importantly, the whole program is designed to find those at-risk individuals and get them into a long-term medical home. We can treat them, we can counsel them on STDs, but if they don't have a long-term medical home, we're just creating a revolving door of infection. So one of the goals of this program is to identify the highest of the highest risk and get them plugged into a long-term medical home. And if that means providing them with linkages to care, perhaps a health navigator to help them identify resources that are available for insurance, whatever it might be, but to identify the highest of the highest risk individuals and get them plugged into services. We've been doing this program initially as a pilot in Dauphin County. And give you an example, our positivity in a family planning clinical-based setting was between 3 and 7%. When we were doing this in a community-based setting, our positivity increased far beyond anything we could have ever imagined. In Dauphin County, for example, the positivity for gonorrhea was running between 15 and 17%. Statewide, our positivity for all our screening endeavors was running around 2%. So we went from 2% in the general clinic setting to well in excess of 15, 17%. For chlamydia, 3 to 7% we were running average. In our community-based initiatives, we were running as high as 30% positivity. So we presented this model to CDC, and with the Affordable Care Act, this is a model that they're interested in looking at and perhaps replicating across the country. We have a very robust evaluation plan that we're actually doing some very stringent evaluation on this, perhaps to serve as a model to the rest of the country. And this is perhaps a method that service delivery can be conducted. So a little bit of background is that for about 20 years, our predominant source of funding was federal funding, and it was really prescribed for clinic-based screening to adjunct chlamydia and gonorrhea to the routine services that individuals were seeking in family planning. And I said it worked fairly well, but that funding, the initiative to solely provide it to family planning in a clinical-based setting really changed. And with the new grant cycle that came out in 2014, we're under a different mandate now, is to go out into the community and find those that are highest risk and linkages to care and also treatment and follow-up. This grant is really entitled to organizations that are dealing with our key populations that are at risk. And later on in the presentation, we're going to identify who those populations are. And essentially, is that if you're working with that population, you're a candidate for this program. Traditional family planning clinics are still an integral part of our screening efforts. We still support a lot of testing in those settings. However, this new push is to get out into the community where the clients that are at risk can be accessed. This new community-based screening initiative is based on a tier reimbursement. We will reimburse based on positivity. The higher the positivity, significantly the higher the reimbursement. There are some dollars also available for outreach, but the predominant focus on this initiative is testing at-risk individuals. And you're going to see in a little while is that we structured the reimbursement in such a manner that at a lower positivity, your reimbursement is going to be X dollars, but at a higher positivity, which York will classify as, it's significantly higher. The positivity for this is going to be calculated twice yearly, and I'll get a little bit more detail later on in the presentation with that. A little bit about morbidity and what's going on in the state, because I got to paint a picture to you of what's going on with the disease burden in the state, statewide, and then also focusing on New York. Gonorrhea, as you can see by this graph, we were on a downward trajectory for many, many years. From 76 to 98, we were making remarkable progress against gonorrhea. And then things change. The organism, especially gonorrhea, has a remarkable ability to adapt to the antibiotics that we're providing it. When I first started with the program in public health about 25 years ago, we had probably a dozen drugs that were effective against gonorrhea. Today, here in 2014, anybody in the audience have an idea how many drugs do we have that are effective for treating gonorrhea that CDC recommends? So when I started 25 years ago, we had a dozen. Today, anybody have an idea? How many drugs do you think are effective for gonorrhea treatment? We have one drug available, and that's an injectable. And already in the world, we're identifying resistant cases to that one drug. So the question is that what happens when we get an organism like gonorrhea that is resistant to everything we can throw at it? What's going to happen is that we're going to have a disease that we're going to have to be giving drug cocktails. Today in Pennsylvania, that one drug is still very effective treatment, but in the Southeastern Asian countries, it's already becoming resistant to that, and it's because of the global connectedness we have. It's just a matter of time when those first resistant cases start popping up in Pennsylvania. You know, in the news today, we're finding out about Ebola, and decades ago, we thought, well, it was isolated to those countries, and here we are finding out that the interconnectivity between our societies allows the facilitation and transmission of those diseases relatively easy. So it's not if resistance is going to come to Pennsylvania, it's when. Part of this screening initiative is to get the disease burden down as low as we can, and also have the infrastructure and capacity out there so when it does come, we can respond to it in an appropriate manner. So part of the reason for the increase in gonorrhea is that we are now limited to the drugs. The other reason is that behaviors are changing. There's a perceived risk associated with having sex, and that perceived risk, it wanes and fluctuates over time. Right now, individuals, there might be a mindset that sex, oral sex especially, is safer than other forms of sex, and that's facilitating the transmission of the disease as well. We have the use of the internet now to pick up anonymous sex partners. 15 years ago that didn't exist. So that's also relating to this increase in disease burden across the state. We also have better test technology. When I first started with the program, the only test that was available for a male was a urethral swab on a culture plate. Now here we are 25 years later, and we have amplified DNA-based testing that we can use a urine sample, and that test is very specific and very sensitive. It can find one DNA remnant of that organism and replicate it many, many times so the test can detect it. A far superior test technology than we had even 5 years ago. So no longer do we give males urethral swabs, but just a simple urine sample. The same thing for females as well. So test technology has changed quite a bit.
You were talking about positivity.
Sure.
Are you saying the number of cases that
Good question. So the positivity is based on the total universe of tests that you're doing and the number of positives that are identified. It's just a simple ratio that we're going to use to calculate it. But very good question. So this slide in a nutshell is that gonorrhea is on the increase, the resistance is on the horizon, and there are many individuals that are at key risk, which we're going to show you in a second. In York County, it follows a similar trend that we're seeing in the state. I would argue, however, is that the increase has been much more significant in York County than we're seeing across the state. Look at the trend from 2010 up through 2013. It has been significant. Gonorrhea is not equally distributed. It impacts certain areas at a higher rate than other areas. And so part of this initiative is to identify where those areas are at highest risk and bring the services to the community rather than have the community come to the facility. Age-wise, gonorrhea is very specific in its age brackets. In Pennsylvania, between 15 and 24 years old, we're accounting for about 60% of the cases in the state. So already we know who is being impacted. It's predominantly 15 to 24-year-olds, and that's about 60%. This data is Pennsylvania exclusive of Philadelphia. I have to make that known because if we included Philadelphia, their disease burden in Philadelphia matches the state as a whole, so it would skew our statistics. We pull Philadelphia out for analysis. But again, at 15 to 24-year-olds, even some would argue 25, is the bulk of our disease morbidity for this particular disease. In York County, it's no different. You see this concentration of 15 to 24-year-olds. And I would argue that as a state, we're seeing about 60-65% in that age group. In York area, it's probably higher, around 70%. It's in that concentrated age bracket. This is the breakdown by race. The state statistics are not nearly as complete, but in New York we have very good demographics as well. 45% of the cases are white, 39% African American, 12% unknown, and 4% other. And it pretty much closely demonstrates what the racial characteristics of the county are as well. So I think the morbidity picture here kind of is representative of that population breakdown. Looking at the geography, where is the disease burden at? Again, it's not spread out in the entire county equally. We have these hot pockets of disease, and this is where the areas where we really want to concentrate the efforts. So we have these clusters. There's a few isolated clusters outside, but within the city proper, we have these clusters of 123 and 103 cases respectively. This is an actual cluster map, and again, we're looking for individuals that are already serving this population, the 15 to say 25 years of age. And if you're in these areas, perhaps we can adjunct this service on top of the service that you're already providing. And that's really the name of the game. We don't want you going out and reinventing the wheel. If you have an after-school program, for example, and you're reaching 15 to 24-year-olds, can we adjunct this piece of testing on top of this and offer a service that's not being offered currently today? Give you an example. In Williamsport, we were working with an organization. They, in Williamsport, there's not a whole bunch for kids to be doing up in that community. It's a city within a large rural county. So we asked the question: where do 15 and 24-year-olds hang out in the summertime? And the community-based organization says, well, that's easy. Everybody who's anybody in that age group is usually at this pool in the summertime. And we asked the question, well, are there outreaches that are going on with the populations at that pool during the summertime? And they said, yes, there are some activities. So we asked the question, can you adjunct this piece on top of that? So that organization went in there and attempted to adjunct those pieces. So the question you have to ask is that within this concentration of disease burden, the 15 to 24-year-olds, where are the kids going? I mean, is there after-school programs? Are there social events? And can we adjunct this piece on top of this? That's really the name of the game. We don't want you going out and inventing a whole brand new program, but to complement what you're already doing with this population. So this map is a very interesting map. We've applied a statistical filter to the data and said, show me a spot on the map that if I was standing in the center of that map, I'd be equal distant to all the cases that were in the city. And so that bright orange spot that you see right here is a point on the map that if I was standing there, and I think we're pretty much standing here right now, we would be equal distant to all the gonorrhea cases that were in the city. I show this map because there are 2 or 3 clusters here that are really important. We have this cluster here, which are the areas that we're in, and then slightly to the east, and then a little to the northeast. And if you were standing in those clusters, you'd be equal distant to all the cases that were in that area. So if I was a CBO, the first question I'm going to be asking is that, what activities do I have that are already doing that are accessing that population that might be at risk? Same thing with this area and this area. And there's lots of things that are probably going on already that, again, might be an ideal fit for this. But this cluster map represents the brightest areas are the areas that would be equal distant to the cases which are in the city. Any questions about that map at all? We'll make these slides available to you offline. I know Linda has your email addresses. We'll be sure to send it to you by email as well. By zip code, because some folks, maps are a little hard sometimes to understand. So what I did here, we broke down the morbidity by zip codes. And you guys know these zip codes. I'm from Harrisburg. I don't know the area very well. All I can do is present the data. But you guys know your community. You know these zip codes. 403, 401, 404, 402. These 5 zip codes accounted for 78% of all disease burden in the county. And within those 5 zip codes, 03 and 01, well over 50% of the cases in those areas. So again, think to yourself, am I serving this population, the 15 to 24-year-olds, and is my service area in those 2 zip codes? And that's really going to be important because with this targeted screening, remember, we're going to be reimbursing based on your positivity. I can almost assure you that if you're testing in the right geography with the right population, you're going to have no problem reaching the highest level of reimbursement because the disease burden is clearly there. All the other zip codes, I should note, in the county, outside of these 5, represent just a 22% of the disease burden for gonorrhea. Now, chlamydia, the nice initiative about this is that with this test, we're getting 2 bangs for a dollar. We're testing for gonorrhea and chlamydia with the same test. And chlamydia is much more prevalent than gonorrhea in itself. Gonorrhea numbers are high, but chlamydia is that much higher. In Pennsylvania, we've been on this upward trend. Now, unlike gonorrhea, chlamydia has not shown propensity towards resistance. Our drugs are very effective. It's an oral medication, and we have no evidence to date that chlamydia is showing the resistance that gonorrhea has shown. Chlamydia still is a sexually transmitted disease. It has a very severe impact. It's the #1 preventable cause of infertility in that 15 to 24-year-old population. Chlamydia is also asymptomatic. An individual can have the disease and never know they have it. And when symptoms do manifest, it's often too late because the damage has already been done to the reproductive system. So think about it. We have individuals, 15 to 24-year-olds, that may not even be thinking of children at this point in time. They have a chlamydia infection. Damage is being done to the reproductive system. And when they are at that point in their life that they want to have children, it may be too late because of the complications that were a result of the infection. In Pennsylvania, I said the numbers have been on an upward trend, and a lot of this is due to behavioral changes and better test technology. As we saw the progression with the gonorrhea and advances in test technology, that same advancements have been effective with chlamydia as well. Years ago, it was a urethral swab for males. Now it's a urine sample. Years ago, the only way a female could get a test was by getting a table exam and a cervical specimen. Today, we have urine and self-collected vaginal. Today, the tests are DNA-based and are much more specific and much more sensitive. So we've made tremendous leaps and bounds in test technology that weren't even available 5 years ago. So part of this increase is a natural increase due to better test technology, but there also is that behavioral component to it as well. And I want to stress that the one test that we do is testing for both those diseases simultaneously. In York County, the disease burden pretty much mimics the state. That same upward trend that we've seen across the state. Age group, guess what? Same population, 15 to 24-year-olds. Whereas the gonorrhea is around 60-65%, in chlamydia, it's about 80% of our disease burden is in that age group. And then in the county, again, a very similar demographic. Quickly drops off after age 25 to a very low rate of disease burden. And there's anatomical reasons why that is. I won't get into it in this audience, but there are some anatomical reasons why disease burden is as it is. Gonorrhea, we do see cases in the older population. Chlamydia, 80% is in this 15 to 24-year-old age group. By race, 54% white, 24% African American, 5% other, and about 17% of the cases we just don't know what the race was because they weren't documented. Whoops. Well, so let me get back to my slides here. It jumped ahead here. So again, looking at the cluster map, where's the disease burden at? Chlamydia is a little bit more geographically dispersed across the county. We have clusters you can see throughout the county, but the bullseye, unfortunately, is in York City proper. 961 cases, and then just to the south, 98 cases. But we have, again, these hot spots throughout the area. So if you're a CBO and you're servicing down with the Littlestown area, there is clusters of cases down there as well. Unlike gonorrhea, it is more geographically dispersed across the county. The numbers are also much higher. Again, same technique here. If I provided a statistical filter and said, show me an area in the city where I'd be equal distance to all the cases, guess what? It overlaps the gonorrhea map almost perfect with the bullseye. It's this general area right here. Well, again, we have clusters across the county, but right here in the center, pretty much where we're standing at is the, if you want to call it, epicenter of the disease outbreak. So again, if I was a CBO, this is one of the areas I'd be focusing on. And I blew this area up a little bit more so you can see a little bit more in depth. Another cluster down in here, but you guys know this area. You know the demographic characteristics. You probably know where a lot of 15, 24-year-olds, where do they go? Where do they hang out? What are the social venues that are available to them? Those are the areas that we want to be targeting and talking about. By zip code, same technique. We took the top five counties, and again, pretty much mimics gonorrhea identical. 403, 401, 18% and 17%. Not quite as concentrated as we saw with gonorrhea, but again, a very high proportion of the cases. The top five counties, about 61%. And then all other counties, all our zip codes are about 39%. So a little bit more geographically spread out. Any questions on the chlamydia? Okay, so let's get into the heart and guts of this contract. How is it going to work? What do we have to do and things like that? First of all, one of the big questions is treatment. We can test individuals, but if we have no opportunity to treat those individuals, that's a disservice. So we have to have a treatment plan in place as we identify these positives. And what do we do and how do we do it? Well, with the Affordable Care Act, the whole supposition is that we need to get the individuals into their medical home. And we realize that for many of the population we're trying to test, the medical home might be the emergency room. That's not an effective way to do primary care or do reproductive care. It's costly, and frankly, they may not be getting the services, the more comprehensive services that are going to be required. So one of the goals is to get them into a medical home. So as we test individuals, that 15 to 24-year-old age group, and those positives are being identified, the first question we have to ask is, do you have a medical home? And if the answer is yes, but by all means, refer them back to that medical home so they can get that treatment and those more comprehensive services. It's an opportunity for the health department to also engage with that primary provider and ask the question, are you testing at-risk 15, 20, 24-year-olds routinely for STDs? And if the answer is no, then why not? We can demonstrate through statistics and everything else is that that's the age group that our practitioners should be testing. But you know where it really hits home at is when they have one of their clients, one of their patients that they see in their practice, and it comes to light that this person is at risk. That's probably a more effective message than anything that we can actually communicate through statistics and such.
Steve, what if that age group doesn't want to use their health insurance because it's connected with their parents and they don't want their parents to know that they just tested positive?
That's a really good point. So this is why the hierarchy is set up. You're going to find that for some teens that's a barrier because the explanation of benefits going home, and they don't want mom or dad knowing that they have a positive gonorrhea or positive chlamydia. Believe it or not, in our university settings, that's an issue because with the Affordable Care Act, they're covered now well into their 20s, but they still don't want mom and dad getting an EOB at home saying that they were treated for chlamydia and gonorrhea. So that's a really good point. So if it's possible and the EOB is not going to be an issue and they have a medical home, by all means refer them to that medical home. It's an opportunity for us to engage with that provider and ask those hard questions of, are you routinely testing? Are you talking to your clients about their sexual behaviors? And are you counseling them on their reproductive health? It's an opportunity to engage, but the EOB is a really big issue. I know there are, with our Congress and our Senate at the national level, there's much discussion about the EOB and how could that be modified where those issues are not going to be popping up and be a discouragement for individuals to get tested. So what's the next tier? The potential for the testing site to offer the treatment on hand. Now I understand that a lot of our testing sites are community-based organizations may not have medical staff on hand. Some of you do have a nurse that's part of associated with your facility. What you can do is that we can provide the drugs for no cost to the client. You actually order the drugs from us, and we can provide them as long as you have a nurse and a physician willing to provide a standing order for that nurse to administer those medications. For the CBOs that don't have medical staff on hand, and we're working across the state with Boys and Girls Clubs, YMCAs, and such that may not have that nursing staff on par. What are the opportunities that exist? Well, you can partner with another organization, and this is part of the reason we brought you guys together is to start talking. Maybe you're an organization that you have really great opportunities to intersect with this population, but you simply don't have the medical staff on hand. Then we have an organization over here that has the excellent medical staff and the outreach capabilities, but don't have the opportunities to intersect with this population. Well, guess what? There's an opportunity here to draw the linkages and the collaborations. This is happening now in Lancaster City proper as well, is that we have some really great organizations that were doing outreach with this population, but they lack the medical staff to provide treatment on site. So they're partnering with Lancaster General Hospital, and they've developed this collaborative relationship, and it seems to be working very well. So the testing site is an ideal place to provide treatment. We can provide those medications for no cost, and there's no EOBs, and the client can get treated and then get referred into more comprehensive services. If you're not an organization that has that medical staff, maybe we can develop a partnership with somebody that does have that and develop those linkages. And if that's not the case, then we have to go up to our third level on this triangle or this pyramid, and that's our existing clinical network. We have across the state clinics that are funded by the state to provide free and confidential STD services. The New York City Health Bureau can provide that treatment as well with a standing order. So if you're a CBO that does not have the ability to treat that individual, or your hours aren't working out, the next tier on this pyramid is to refer them into our existing clinical network. There are New York City Health Bureaus available, and we have contracted clinical sites that can offer that treatment and the comprehensive exams that those clients would require. I would argue that if you're the testing site and you're doing the testing, you already have that collaborative relationship, that trust that individual for the test, because they gave you a sample and have provided you an opportunity to test them. Does it not make sense then that they'd be willing for you to provide that treatment as well? So it's really a good opportunity.
time between taking the urine test and a result?
Okay, that's a good question. So it is about 24 hours, and I'll tell you why. Because we use a laboratory that's contracted out of Texas right now. It's the current awardee of our contract. It's United Parcel Services picks it up and it's overnighted to Texas. They process the results that morning, and usually with that afternoon, the results will be waiting for you in a secure log on site. And so it's usually about 24 hours. I say that because if there's delays in weather or whatever, and UPS can't get their flights out, it could be a little bit longer. But in general, the system's about 24 hours. So they overnight them, the laboratory runs it, usually you have the results by the next afternoon or evening. So it's a pretty quick turnaround. It is not a rapid test, however. So if the testing site can't provide treatment, we have the existing clinical network. And in some rare situations, we have field staff. Stephanie, Linda are available. And in some rare situations, we can provide the treatment directly to the client. But I say that's rare because there's only 2 of them, and they're covering this large area. It's a limited resource. And there are some reasons why we would do that, but they are limited, and so that's why they're at the very top of the pyramid. We don't want to overuse it because it's physically impossible to treat all the cases that are out there. So as a nutshell, it's really the patient's medical home is a preferred method because of EOBs and clients not having a medical home. It's a testing site, and if that's not an option, our existing clinical network. And I said, in very few cases, it's the field staff that we have available. Any questions on that treatment model?
Steve, I'm just wondering that when patients are going to their medical or the private practice physicians, sometimes the issue that arises is that they notify a parent of the result. They don't notify the population, the children themselves. That can sometimes be a barrier too, or sometimes then you have to go through the hierarchy of other
Yeah, absolutely.
clinics can treat the kids.
Absolutely.
Field staff can work. They're notifying parents, so they don't even want result back. If they're not being prophylactically treated at that visit, they don't want that phone call to find it with their results.
Absolutely. So that's a really good point. And really, we're seeing this as an opportunity to educate providers. Not only are you testing, are you asking that sexual assessment, but also show them or maybe do some role playing with them on how they can notify that client. So it's a really good opportunity for us to outreach to providers. We can send as many, health alerts or flyers or whatever it may be to the providers, but until you actually bring it home to their client that they're serving, it really doesn't hit home. And I think this is a good opportunity that will present itself. Any other questions about treatment?
Just a comment. I think you bring a good point about contacting this 15 to 24-year-old. They all have cell phones pretty much now. They all have more electronic ways of being contacted directly.
Yep.
So maybe if it's at the primary care medical home, they can ask the teen or the young adult how do they want to be contacted. Maybe that phone call to the parent could be avoided, and they could be contacted directly through their cell phone or something.
That's a really good point.
Text.
Yep, text. And I'll give you an example. We have a CBO, is in the Pittsburgh area. One of the methods that they have identified to contact the individuals that are positive is simply send them a text saying that your flowers are in. It's a code word that they developed with their clientele that they simply text and say your flowers are in. And when that client hears that, they know that they need to call the clinic. And if somebody intercepts that text message, it means nothing. So kind of innovative, and they're using texting as the primary mechanism to notify those clients that their flowers were in, which is a code word for their test results were in. So think outside the box. As Dr. Hawk mentioned, our teens, these 15 to 20-year-olds, live and die by their cell phones. It's funny because rather than communicating orally with each other, they might be sitting right across from each other. They're texting each other. I'm like, what is that about? Just talk to each other. But they text, and that's how they live and die by. So let's use it and let's leverage it and think outside the box. One of the things we do have to maintain with this population is confidentiality. Really, really important. So as you as an organization are thinking through about perhaps engaging in this endeavor is that we really need to think through the confidentiality of it. We have to maintain that at all costs, because if we lose confidentiality, we lose the whole entire thing. I want to talk about syphilis a little bit. And no, we are not testing for syphilis in this initiative. But what we are doing is we're identifying the highest of the highest risk, which allows us an opportunity then to offer additional services. If you're positive for chlamydia or gonorrhea, your opportunity to get an HIV infection, anybody in the audience have any idea, what is your chances if you have chlamydia and gonorrhea and you're exposed to somebody that has HIV? What is the rate of increase that you just exposed yourself to? Does anybody have any idea? 75%? No, that's really high. It's a 5-fold increase. So if you have chlamydia and gonorrhea and you're having sex with somebody that's HIV infected, by you having that concurrent infection because of all what's going on with your immune system, you just increase your risk of acquiring HIV from that individual by 5-fold. If you have gonorrhea and chlamydia, we know that you are engaging in unprotected sex, and that person has syphilis. Well, guess what? Now you're at risk for syphilis as well. So part of this endeavor is to identify the highest of the highest risk and offer those more comprehensive services, such as an HIV test, such as a syphilis test. If that client has insurance, why not then offer them a hepatitis panel for screening as well? Perhaps they also have herpes and then they don't know about it. If they have access to insurance, to offer those more comprehensive services. The other thing is that, are they using birth control? Do they have access to birth control? Again, expanding out those services that are going to be needed with those individuals. We want to stop that revolving door of infection that goes along with it. I bring this graph up because in Pennsylvania, most of our early syphilis cases have been predominantly in the men who have sex with men population. About 90% of the cases statewide has been in that population. We've seen tremendous increases in that disease in the MSM population. However, as of recently, we're seeing a demographic shift in that disease burden. We're starting to see some spillover into the heterosexual population, and as we see that spillover, right behind it, inevitably, is congenital syphilis. Congenital syphilis is when a mom has syphilis, she is pregnant, doesn't know that she has it, and the baby acquires the syphilis infection from the mom because mom's been untreated or untested. Although this screening endeavor is not focused on syphilis, we're hoping to identify the highest of the highest risk, and if those individuals that are positive can offer a syphilis test, perhaps we'll also find some individuals that may be pregnant that were unaware of it, and also offer them those more comprehensive services. One of the things that is interesting is that as that ratio of cases switches from MSM to heterosexual, we approach that 80-20 rule, where 20% now are heterosexual and 80% are MSM, it's almost as if a trigger has been initiated where we see congenital syphilis cases popping up in that county. Erie County, for example, hasn't had a congenital syphilis case in many, many years. This past year, they had a congenital syphilis case. Guess what? The ratio of early syphilis cases in that county went 80-20, and right behind it was a full-blown congenital syphilis case. In Pennsylvania, to treat one congenital syphilis case, you're talking about lifetime costs in excess of $250,000. Syphilis can be treated in that baby, but any manifestations of that disease are permanent and long-term. So any neurological damage, cardiovascular damage, respiratory damage, it's permanent. That child will have to live with that the rest of their lives. So again, the screening initiative is not focused on syphilis, but we're hoping to identify the highest of the highest risk and get them tested and treated and offer those services. In York, just to show you the male-female case breakdown, it is predominantly MSM, but we do have these female cases. And in a second, I'm going to show you the age breakdown as well. So in Pennsylvania, look at this. 20 to 24-year-olds, we have a spike in cases. So if we're offering chlamydia and gonorrhea, we identify the positives. Well, guess what? It's an opportunity to refer this population for those more comprehensive services and perhaps identify a civil case that we were unaware of. And perhaps, if it's a female and she's pregnant, we have averted congenital syphilis case as well. We can also then test these individuals for HIV. Fortunately, in Pennsylvania, the HIV incidence in this population here is small, but if you have gonorrhea and chlamydia concurrently, you're at much increased risk, and we can offer that HIV test as well. And then the other thing with syphilis, the spike here after 35 is predominantly our MSM cases that we're seeing across the state as well. So in New York, look at this. 15 to 25, we have a big spike in syphilis cases, and then another spike at the later ages. Perfect opportunity again to offer those more comprehensive services once the positives are identified. So part of the game plan is that if you're a CBO and you're going to be offering these testing services, we want to think big picture as well. Is that these are going to be clients that we identify that are positive to get them treated, and then let's just start to think about the next game plan is how to get them into more comprehensive services. What resources are out there? This is the opportunity to start partnering and networking with your colleagues here in the office, is that you may have a piece of the picture and a piece of opportunity here, and this group over here has something else that can be offered. And then how we knit this all back together again to offer that complete service to that client. I know with Health First, I'm going to put a representative from there. I know there's health navigators that may be available. We can talk about that because I understand navigating, trying to get an Affordable Care Act and all those things that are options, it's quite difficult. So maybe there's a health navigator we can link that client up to and such. So really, the name of this game is not only the testing and identifying the positives, but the more comprehensive services that can be offered later on. If we're simply just testing and treating and not offering the more comprehensive services, we've created a revolving door of infection. So our hope is that we get the positives identified, get them into service, and continue this feeder into the system.
In addition, it gets them comprehensive reproductive health and possibly birth control they may not, or using barrier contraceptive, which they may not have done before. So that's another whole other piece of that when you hook them in.
So, the state of Pennsylvania, we've not always made contracting the easiest thing to do with us. We have tried to streamline this as possible, to make it as easy and as efficient for an organization like yourself. So what's the process here? The very first I'm going to hand out here is a sheet. It's a one-sheeter. If you're a CBO and you're considering doing this, and you met with your board or whoever it is that says, yes, we can do this, we're going to ask you to fill one of these out. It just tells us who you are and what you're planning to do. The moment you fill this out and we receive it, we start this pilot phase. Say up to 60 days. And what it allows you guys to do is go out and start initiating your plan. And we're going to be measuring your positivity. That's the total number of tests that you've done versus the positives that you were identified. So if you do 100 tests and you identify 10 positives, your positivity is 10%. And then we'll follow that and use that for that grid for reimbursement. So this is the very first step. And many CBOs, they take the information back, and in some cases, I've been asked to go back and present the same presentation to their board of directors because there's some questions they may have. I have no problems or no issues with that. If it's needed, so be it, we'll do it. When you fill this out, we set you up with a lab account. And the moment you tell us you're going to start, we start your 60-day pilot. It doesn't have to go to 60 days. If right out of the gate you prove that you have a positivity that's in excess of 3%, we can stop right there. Just a 60-day pilot is an opportunity for you to understand what you're doing and tweak your systems so you can reach at least 3% positivity for chlamydia. We're using chlamydia positivity as the marker for this contract because it's a much more prevalent disease than gonorrhea, but 3% is the minimal threshold. And I said, if out of the gate you're getting a high positivity, we can stop the pilot right there and go into the next stage, which would be a full-blown contract. If you're struggling as an organization to reach that 3% positivity, we'll work with you to tweak what you're doing so you can reach that minimal threshold of 3%. We've had in organizations their first testing event out of the gate, they were 12, 14% positivity. No reason to go on trying to do a pilot. They proved it. We initiate a contract and move on. So it's a very quick process. Now I'm telling you, here in the city, the disease burden is high enough. The populations are clearly identified that if you're reaching 15 to 24-year-olds in those key areas, there should be no reason why you can't meet that minimal 3% positivity. We did a screening at the York High School several years ago and tested a large number of kids, and right out of the gate we got between 7 and 10%. And that was just the general population that we were testing there. So again, you should have no problems reaching that minimal 3%. During this pilot, we'll provide you the test kits. I'm going to show you in a second how easy it is to do this test. If you have the capability of doing treatment, we'll also provide you the medication to treat on site as well. If you do not, we'll have to figure out a game plan on how we're going to get those positives identified. And we'll work with you again to identify how you're going to treat that. If it takes 60 days and you still haven't reached that 3% positivity, we'll have to reevaluate what you're doing and how you're doing it. But again, in this area, it shouldn't not be an issue at all. If after the pilot you struggle getting minimal 3%, it's probably not a good fit for your organization nor ours, and we'll probably just walk away and there'll be no harm done. Greater than 3%, we'll start the contract and the reimbursement phase of this initiative. The reimbursement is based on 4 tiers. You're going to see a price structure here that really leans heavily towards the positivity. So between Tier 4, which is our lowest reimbursement, is greater than 3% and less than 5%. The reimbursement is $12 per test. So if you do 100 tests and you have 3 positives, you're going to get reimbursed $12 for every test that you did. So your reimbursement for that 100 tests is going to be $1,200 right out of the gate. We pay you for every test that you did, not just the positives. At Tier 3, it jumps up to $18 per test, and that's between 5% and 8% on positivity. And then we go up to Tier 1 is $45 per test, and that's for positivity in excess of 10%. I would argue what I would expect in New York City, targeting those zip codes, targeting that population, you should be easily, as a CBO, either between Tier 2 and Tier 1, just based on what I know of the disease burden and similar initiatives across the state like this. So you're talking between $36 and $45 for every test that you do. The state will generate the invoice for you. We use a lab, again in Texas, every day we get an electronic file from that laboratory. So we're actually using that laboratory's file to generate the invoice for you. So there's really very little paperwork that's needed. Every month, we simply go in by your site account number and generate the number of tests that you did for that month and ask you to affirm that invoice is correct. And it's based strictly from that laboratory file. Your positivity will be evaluated twice yearly, once in July and once in January, and it's based on 6 months. So your reimbursement is established in 6-month increments. So say during the winter months, you're out screening and your positivity is 8%, you're at $36. And then in the summertime, because the activity is increasing, we'll reevaluate, and if your positivity jumps up to greater than 10%, your reimbursement for the next 6 months will be based on that, for that July evaluation period. We did it in 6 months because positivity can go up and down every month. We figured 6 months was an adequate period of time to evaluate. And we're finding out that if you're targeting the right population and your positivity is high, it's going to remain high because the disease burden, you've hit the populations that are clearly at risk, and it doesn't really vary much from month to month. Any questions on the reimbursement schedule? So again, it's strictly calculated on what you're testing. The reimbursement is based on every test that you're doing, and we'll evaluate twice yearly, once in July and once in January, and that determines the reimbursement rate going forward. That's the key, that's the heart of this contract. There is one other piece. is that we're allowing the site to bill us up to 32 hours of outreach per month as well. So if you're doing outreach, because we realize in some venues, you're going to have to do some upfront work to get the populations that you're trying to test to the table to get tested. So for up to 32 hours per month, the reimbursement is based on 2 tiers again. During the normal work day, 8 to 5, Monday through Friday, we're going to reimburse $25 an hour, up to 32 hours. However, if you're doing outreach during weekends, during the evening, during holidays, whatever it might be that are beyond that traditional work week day, the reimbursement is at $40 an hour. This is the only piece of paperwork that you have to submit every month, is to tell us what the venue was and what hours you worked for the outreach and how many hours it was. That's the only thing you have to submit. Now, one of the joys about this initiative is that we structured the reimbursement in a method that is fairly significant. You as a CBO can do a lot of things with that reimbursement that we as the health department cannot. I'll give you an example. That Williamsport initiative, they're thinking, well, how do I get 15 to 24-year-olds to come even to my table to talk to me? Because you know, if you've dealt with 15-year-old boys, they can be quite immature and they can be quite intimidated by anything. So how do you get them to come to your table? One of the things that Williamsport did, I thought was quite unique, is that they said, listen, we believe we can get $42 reimbursement because we think our positive fee is going to be high enough. We're going to take a small percentage of that and buy an incentive to bring those kids to the table. So what they did is that one of the ladies that was in that group said, you know what, I know the guy who owns the Verizon store. I'm going to walk down and see if I can get him to donate a phone. You know, these smartphones are the rave right now. And so maybe every kid that comes to my table, regardless if they get the test or not, will be enrolled into for a phone service. And maybe I can take a small piece of that reimbursement I get and offer them a free contract for that 1 year for that phone. Well, that's a sweet deal. So those 15-year-old boys that are standing around punching each other and say, you go first. No, you go first. Well, maybe that initiative then allows them to break that hurdle and actually come to the table to talk about the risk associated with chlamydia and gonorrhea. And what we have found out is that if you can get them to the table and you can talk to them privately, one-on-one, about their risk, they know what they're engaged in. They know the activity that puts them at risk. Maybe they'll step up and give a test for chlamydia and gonorrhea. But how do you break down that hurdle of getting them to the table? And that's what I'm saying is incentives would probably be the best endeavor there. We can't, as a department, offer that. For me to go out to a Verizon dealer and say, give me a free phone and a free contract, probably 600 documents later, you know, several meetings with the attorneys and everything else, maybe in 6 years I could get it done. You as a CBO have a much more latitude and freedom to do that we cannot do. So as you think about this endeavor, I think incentives are going to be a major piece of this, and you know the populations you're going to be working with. What are those incentives? It could be iTunes cards. It could be a McDonald's coupon. It could be that you go out and buy an iPad, and everybody that comes to your table will get into a drawing for a free iPad at the end of a certain period of time. You know those incentives better than we do, and I would encourage you, because I think it'll be a draw to allow these kids to get tested. This is just an idea, but we can't offer incentives because of the structure that we have. Okay. Any questions about this reimbursement at all? Beth just handed out the contract. The first pages of the contract, let me get the contract and walk you through this. It seems much more complex than it really is. The areas that you really want to concentrate on are probably the first The first 5 pages are really what's relevant to you as an organization. Everything else is the legalese that we have to put in every contract that we offer across the state. This is for your attorneys to look over later on, but the meat of this contract is the first 5 pages. This really discusses what you're going to be doing and how you're going to be doing it. It's a relatively straightforward boilerplate contract, and it allows us the mechanism to provide that reimbursement to you. Now, in regards to that pilot, During that pilot phase, the only thing we're going to be doing is providing you the free test and the free medication if you have it available. There's really no reimbursement because we don't have a legal document in place yet to actually provide you reimbursement. However, if you get a remarkable high positivity and we can prove that you don't have to go through that whole 60-day pilot, we'll just retrograde the contract back to when you started and attempt to reimburse you for the test that you had already done. It all depends on where your positivity falls in. But I want to be clear with you, is during that pilot, we really don't have a mechanism in place to provide reimbursement because there's no legal authority for us to provide that reimbursement. But if you are successful, you demonstrate the positivity out of the gate, we'll start the contract back from when you started the service. And we'll work with you as an organization to determine that. All right, well, training resources is our next part of that contract. There is some minimal training required. We figured that if you're going to be talking to kids about chlamydia and gonorrhea, you need to know a little bit about chlamydia and gonorrhea because they're going to be asking you questions and you need to have an opportunity to provide accurate medical information to them. So the training is very minimal. CDC has a web-based training called Passport to Partner Services. Any public health professional that's coming on board for the STD program that's going to be working within the STD program has to take all these modules. We're not asking you to take all the modules. We're asking you to take 2 of them, the chlamydia and gonorrhea module. They're self-paced and there's a post-test afterwards. In addition to that, we have opportunities for you to shadow maybe a family planning clinic and an STD clinic. We can come down and work with you one-on-one to provide that training as well. And so between the PA Department of Health and the organizations that we contract with, if you're a little bit uneasy about how to do this, then we'll provide those shadowing opportunities one-on-one with you to get you to that point. I've worked with organizations in the State College area. Pregnancy Resource Center, for example, was kind of new to this, and they want hands-on training at a clinic. So we arranged for opportunities for them to actually go into an STD clinic and shadow there for 2 days so they can get comfortable with how to interact with the client, what to tell the client, and things like that. What we're saying is that we're not going to hang you out there by yourself and say, congratulations, go out and do testing. We'll meet you where your needs are and provide that additional training and that networking opportunity. Now, in regards to the test, I need 2 people from the audience to come up. We're going to do a little demonstration to show you how easy it is to do a chlamydia test. So just 2 individuals. There's one, and how about somebody from over here? There's 2. All right, come on up here. So, the laboratory provides you these hermetically sealed test kits. Everything you need to do in this test is contained in this hermetically sealed bag. So, what you're going to do is ask the client to provide you a urine sample. And that's probably a pretty good sample right there. And you're probably going to have gloves on when you're handling this because it is urine. And sometimes, the kids, they cross-thread the lid or whatever it might be, but that's pretty easy to process. They provide that urine sample. And what you're going to do, you're going to have gloves on, of course. I'm going to let you guys open these two bags up. That's the hardest part of the test, is getting these bags open. See, you guys struggle. I struggle with it. I'm ripping and tearing. There's a trick there. So you're going to take out a little pipette there. All right, now, if you're really good with this, you're going to draw up a urine sample in that pipette. Now, you guys can't see. I'm going to pass this around. On these tubes, you're going to see 2 markers, 2 lines. That's where the urine has to be in between. So I'm going to pass that around so you guys can see that. And I'll do one over here as well. There are 2 black lines to show you how much urine has to be in that tube.
And the lab is very critical.
Yeah, the urine has to be between those 2 lines. There is leeway there, but the lines are about that far apart. But the urine has to be in there somewhere in between those 2 lines. So now, I'm the client. I come back. You've counseled in chlamydia and gonorrhea. I'm going to give you a chlamydia or urine sample, and you're going to go ahead and actually do the specimen process. To take the tube off, you're going to draw up urine in that pipette. You want to get a good swig of that in there. And you want to get it in between the 2 lines there. All right, you're good right there. That's perfect. And that's perfect as well. You guys are both perfect now. You are trained urine drawer now. And so the test is relatively straightforward. This is going to get thrown out, it gets dumped in the toilet, and the cup gets disposed of. Now what's going to happen, thank you very much. So, was that hard?
No.
No, very, very easy. So what's going to happen is that the laboratory will provide you a printer, and you will need access to a laptop computer because you're going to pre-register all your clients onto a web-based secure application. The printer will spit out a barcode label. You simply label that barcode on the tube there. It just sticks right on there. You drop it in a box, and United Parcel Service comes and picks it up for you. About 24 hours later, you'll have access to a secure website. You'll log on, and your client's results will be there. And when they call you, you'll be able to provide those test results in there. And we'll coach you and counsel you on how those results could be provided. Simultaneously, any positives that are identified are also going to be reported to our PA Net system automatically. So the reporting is already done on your behalf. You don't have to worry about that at all. It's automatically reported. If you're a provider that's going to be providing that treatment, the only thing we're going to ask you to do is log in PA Net with the accession number and the last name and document the treatment of that client. If you are not providing the treatment, we'll handle it over here on the Department of Health side and develop a mechanism to do that. Really relatively straightforward process. This is the website for the training. There are 13 modules on there. The only two that we're going to ask you to take is the gonorrhea and chlamydia.
Steve, I also put copies of their training in their yellow sheets.
Well, very good, excellent. So there are a bunch of modules in there when you go in there. The two that are required are chlamydia and gonorrhea. Anybody who's being involved in this outreach is required to complete those two modules. We're going to ask you to get an 80% on the post-test for those modules. You can take the test as many times as you need to. So if you take the test the first time, you get a 72, you can retake it again and get an 80%. The reason we're stressing that is that we want to make sure that when you're engaging those clients about gonorrhea and chlamydia, you can provide them accurate medical information because there's an opportunity to provide some education to the individuals that you're going to be testing. In addition to this, if you're so inclined, there are some recommended modules. They'll give you a really, really good foundation on STDs. They're not required, but they are kind of nice to add to it. You're looking at about a 2-hour commitment here for the chlamydia and gonorrhea to complete that module. And there's some additional hours if you're so inclined to take the ones in blue. There are a bunch of other modules on there. They're not required. Again, this is the public health training that any public health professional is required to take if they're going to be working for us. And I said these are self-paced, web-based, post-test, very professionally done. Gives you a really good working foundation on chlamydia and gonorrhea. Any questions on the training at all? There's this. Go ahead.
I'm not a nurse, but I do deal with a lot of young people in the community, Hispanic people, and for the research and materials, do you have those in Spanish?
Yes, on the CDC website, there are a lot of fact sheets that are available. They're both in English and Spanish, and they are downloadable in PDF as well. So yes, there is Spanish out there that are very easily. If you go to our website or the CDC website, just put STD in there, and you'll see all the fact sheets. And they're both in English and Spanish. They're very easily downloadable.
There's also a GYT, Get Yourself Tested, website also that has English and Spanish, and it's more geared to teenagers than the CDC website would be. And the materials are a lot more edgy or a lot more fun, and those are downloadable as well. And that was a joint project between CDC and MTV actually. GYT, Get Yourself Tested. It's yourlife.org, I think, is the actual web address.
So, in addition to the urine, we have found that some young girls have difficulty peeing in a cup from experience. They just can't do it very well. So we explored some other opportunities out there, and there's a self-collected vaginal specimen. Where's those test kits? There's one there. I actually passed out the vaginal one to show you. This is a self-collected vaginal swab. It's for girls, it is one for females. But it's a test that you can give them if they're going to have difficulty aiming for the cup. You can give them one of these. And what it is they can go into the bathroom and provide their own specimen. If they get in the general area, because this test is in a DNA-based model, it'll pick up the DNA from that organism. So they don't have to be very precise. As long as they get in that general area, if they have chlamydia or gonorrhea, the test will pick it up. We found that for a lot of young girls, this is the preferred method. Very easy as well. Hey, look, I opened it up on the first try there. Usually I'm up here struggling. You give them the tube, you give them the swab. They take the swab out. There's 2 of them, so they drop one on the floor, no big deal. They go into the bathroom. They get in the general area. They open the tube up. This swab is scored. It breaks off. And they come out and they give you the tube. That's it. So for females, they're going to have a problem providing a urine sample. This is another method. Just as good of a test and very easy. We have really good reception on this test as well. And all you're getting is a tube. You label it, drop it in a box, and send it to UPS, and they'll pick it up and send it down to the laboratory. With regards to UPS, the laboratory has a contract with them. You call them, say I have a pickup, and you can pick up. You can even take it if you're on the way home and you have a box. You can drop it off on the UPS pickup stores, and they'll pick it up and send it down to you. I even heard of CBOs. They see the UPS driver and they just wave their hand and give them the bag that way. Everything is self-labeled and postage is already paid. So very easy, and I say overnight mail down to our laboratory in Texas. In addition, for training resources, we have these flashcards. They're about 11 by 8.5 that also demonstrate how to prepare the test specimen as well. They're in English and Spanish as well.
I put a copy of that in the folder.
Well, excellent. Very good. Any questions thus far? Okay. Now, we have this, we've done the task. How do we communicate these results to the client? That's really an important thing, because you're going to have negatives and you're going to have positives. How do we do this? So you as a CBO is testing the community. We think this is a great model because there's a mistrust, there's suspicion from the health department. It's just the way it is, because we represent the government. There's individuals that are reluctant to even engage with us. You as a CBO have that trust already. You're already working with the population. You're ideal to offer that testing service. So you're testing out in the community. You do the test, you send it by UPS down to the laboratory. 24 hours later, the results are available for you to download and communicate those results to that individual. We're going to ask you as a CBO to communicate those negative results to those clients. And it could be as simple as texting them and saying your flowers are in. They call you back, you demographically challenge them who they are. So Mary Sue calls and says, I got a text that my flowers are in. Well, the very first thing you should do is say, Mary, what's your date of birth? If they struggle and say, 10/15/95, well, you may want to challenge them a little bit more because it maybe is not Mary Sue. Everybody knows their date of birth. So you challenge them a little bit. And if you're comfortable that it is Mary Sue you're talking to, then you can say, Mary, your test results were negative. You know what we talked about, engaging in safe sex and using a condom consistently, and then that's the end of the conversation. If they're positive, this is in the confines of the Health Bureau now, they'll work with you on how those positives should be notified. And that's something we'll have to discuss, is that do you want the CBOs doing it, or do you want to handle all the positives? It's something that we'll have to talk about. Different municipalities have done different things. Some municipalities have said, don't worry about the positives at all. We'll contact them on your behalf. You don't even have to deal with that part of it. Other ones have worked in collaboration. So that's something that has to be yet worked out. When you're at that point, we'll have that thoroughly vetted and give you the instructions on how to do that. If you're going to notify the positives, you need to have that game plan in place of where do we get them treated. Are you as an organization going to be able to treat them? If not, do you have a partner agency that you've partnered with that we can refer the clients over to? If not, is it York Health Bureau? And if not, if it's one of our contracted sites. So we have to think that through. That's an individual customized thing. We're going to work with each of you to figure out how to do that. So the deposits go into PA NEDs. We have represent, we'll be following up on that as well to make sure they're treated. If you are treating, you as the agency or whoever's treating it are responsible for documenting that treatment in PA NEDs. And that's a relatively straightforward process. You log on to a website, you have the accession number of a specimen. The accession number is just the lab ID that they provide. It's on that little sticker that they're going to be on the tube. And the last name. With that, you can go in there and document the treatment. It's a 15-second process. But it prevents Linda from having to follow up with the client to see if they were treated because it's already been documented on that behalf. And then really, after that, is getting that client linked to more long-term care, getting him into a health home, getting him into reproductive care that they may need, and those referral services are so desperately needed. In order to get reimbursed, there's one other step that you have to do, and you have to register as a vendor in the state. In order to do that, in order for us to pay you, we have to have a place to send the check, and you have to be recognized as a vendor in the state. This website, it's in your package we'll be sending out, actually walks you through how to become a vendor. We have all kinds of individuals registered as vendors in there. It's just that piece that you need to do so we have a place to send a check and recognize, because there's tax purposes and things that have to be clearly enunciated as a provider. So if you're interested in doing this, what I would highly recommend is you fill out the screening sheet. You can send this to us by email or fax. This is the first step in the process. It tells us that you're interested. When we get this, we'll set up the lab account with you, start you with your training, and get all that stuff initiated. If you're doing this, I will also recommend that you simultaneously register as a vendor in the state, because this could be about a 4-week process before they turn it around. If you know you're interested, and say, for example, that you can't get the positivity, there's no harm in registering as a vendor for the state. So there's nothing you can lose from it, but I would recommend you start the process so we can get that, when you are successful in identifying those positives, we can get you reimbursed in the quickest manner possible. So I would recommend that you pursue that as well. So that's pretty much the initiative. I'm sure there's lots of questions going on in your mind right now about how do we do this? Is this a fit for us? What do we do about treatment? Our hope is that you guys can start talking. That's why lunch has been provided, so you don't all disappear, but you can actually start talking to each other and say, you know what? We can do the outreach part of it. I'm a little fuzzy on the treatment. And maybe there's somebody else over here that says, we can provide the treatment, no problem. You know what? If you're a large health organization or a primary care physician or a hospital, those individuals that they're identifying over here as positive can be your future clients to the Affordable Care Act that actually can turn into reimbursable clients. Because just think about it. Gonorrhea and chlamydia are being offered here. Those clients need an HIV test, they need syphilis, they need a full exam. Those are all things that can be billed under insurance if we can get the EOB taken care of. So there's opportunities here to turn individuals that we're screening here into full-fledged paying clients over here through insurance. That's what we're asking folks to think about. Any questions, issues that are burning right now that you need to think through? I have my business card here. Our emails are on here as well. I'll just pass these out. There's also slide presentations. Pass these around. We've had opportunities to partner with Boys and Girls Clubs, pregnancy resource centers, financial counseling facilities. To give you an example, in Lancaster, we have an organization, SACA, that you may be familiar with. They provide predominantly financial counseling to individuals, the Hispanic population. They adjuncted this service onto what they were doing because they were trusted in the community, and folks that were at risk were coming into them. So they have expanded their model. So again, the key thing is that don't think so much that I've never done anything medical. The thing that we're interested in is that are you working with the populations that are being impacted, and can you easily adjunct this service onto what you're already providing? That's really the key. So this is an opportunity for questions and answers. And
So one question. In terms of preventative education, we don't do testing like that, but we do have contact with that population. But we're strictly an educational service, so we have a grant type thing that would get us to be able to go to the high schools and get the SCS.
so perhaps there's an opportunity to partner with an organization that's willing to do that test. I would re-ask the question to you: is that what precludes your organization from doing testing? You see how easy it is and
We're
straightforward.
not a political people, there's no.
But we have many. I'm a strong salesman here.
Yeah, no, I.
There are many organizations that aren't testing either, and they this is easily done. That's what I'm saying.
We're considered an abstinence-based service, we do education.
Okay, we have lots of abstinence organizations that we're partnering with that have adjuncted this service onto their platform. There's nothing inconsistent.
Like you said, I can see there's not doing the testing. What I'm looking for is the funding for the education.
At this point, this contract is predominantly test-based. That's where an opportunity to partnership with somebody and say, listen, you do the testing and we'll partner with the education piece. There's an opportunity there. But I'm also saying that there are lots of organizations we're partnering with now that are like you that have jumped to the testing part because it's so easy and pretty efficient. And you're already intersecting with the population. It's a missed opportunity. And if you need to, I'm willing to come and talk to your board of directors and do that. I've done that many, many times as well. There is a hurdle that has to be overcome. I understand that, and some trepidation. I think we can lower that down. If it's needed, we'll come out and redo the presentation with your board and talk one-on-one with them as well. That's perfectly we're willing to do that.
We have some kind of program that starts from early age to teach kids about these terrible diseases. How can we prevent them before they start with active sexual life? How can we prevent that?
Advocatesforyouth.org, I don't know if you've ever been on their website, has some amazing teaching tools from zero to all the way up for teachers, parents, community leaders. They're based out of Washington, D.C. They're a nonprofit organization, but it's advocatesforyouth.org, and they've got teaching tools, what to say to your 3-year-old when they're asking about their private parts and how to talk about that in a way that's not invasive, a way that they understand, and then it goes up the spectrum as they get older.
The answer to that other question is the Department of Education has recently also received a grant from CDC to do some outreach around sexual health, around abstinence in some key schools. That project is just starting off, so there's some opportunity there as well. That program is just started, and they're still trying to work with the schools to figure out what they're going to be offering in various schools, because it is like kind of an a la carte approach where one school may do this, where another school may do this plus this. So they're still working out those details, but there's another opportunity there as well. I don't know all the schools offhand that are participating in that.
One of the things that CDC is really pushing for, I guess, and through education as well, is that a comprehensive sexual education. And then those who are sexually active, making sure they're getting screened annually, making sure that they're getting to reproductive health, and making sure that they're then, of course, using proper methods of birth control. So it's like all of this is like a sexual health kind of piece. So it's abstinence kind of plus, and then testing and prevention on top of it, if they are indeed sexually active.
How often would you want like a community organization to test? Like my idea was to do like a monthly health fair, like at the YMCA, and then have people from the community come in like maybe like once a month. Is there a requirement of how often?
It's really what your capacity and infrastructure will allow you to do in a reasonable manner. So we have some faith-based organizations that we're working with in the Pittsburgh and State College area. They're doing it twice weekly, but they didn't go from twice weekly right out of the gate. They start off very much like you did. We're doing it once a month. and then as they saw the need and the scope, they gradually expanded it out. So I use the faith-based examples because this was all brand new to them, and they didn't want to get into something so deep that would overwhelm their staff and their resources. So they started off very slow in a very measured approach, and then as they got comfortable with it, gradually expanded it out. So yes, whatever your infrastructure, whatever your capacity could support, we'll be willing to work with you to start off in that measured approach.
I have another question. Is this just for agencies? Could somebody independently, like, organize?
Yeah, realistically, yes. You still have to go through the vendor process. You still have to go through the modules. You still have to go through that pilot phase of identifying. But yes, there is an opportunity there. There's nothing that precludes that from happening.
Do you have any schools that are doing it?
We do. John Harris High School, Lancaster, and Chester Upland. Now, schools are a difficult endeavor. I do need to be clear with that. Is that schools, because they have boards, they have things like that, they're very political sometimes. So what we have recommended with the schools is that it's best for an organization, if you already have an inroad in that school, to work it that way. To approach a school and say, can you do chlamydia and gonorrhea screening with your school nurses? It isn't going to happen. If it does happen, the political blowback sometimes is not always the best. But if you're an organization, I'll give you an example, say Mothers Against Drunk Driving, and you're going into a school ready to do a program, and you say, you know what, we can make this work because we're already in the schools, and maybe you can make a correlation between drunk driving and drinking and STDs. You can. I'm using this as a hypothetical example. Well, maybe then the organization does the testing and the school is just facilitating it. We've had situations where school nurses have been involved directly, and if the board changes and someone gets on the board that's against this, it can make that life for that school, for that nurse, quite miserable. But if you're a community organization going in there, the worst they can do is ask you not to come back. No one's going to lose their job. No one's going to lose political blowback per se. So my recommendation is, yes, schools are a great opportunity, but they're also fraught with lots of political obstacles as well. If you're established in that school doing something else, this is an opportunity to then adjunct those services onto it. So yeah, schools are great opportunities, just that you have to be a little more careful in negotiating the political terrain of those and getting in there. And we would much advocate that if you're a CBO already working in a school, that maybe you look at adjuncting and working quietly behind the scenes to get the administration on board and things like that. Because if the school does it, it draws a whole bunch of different attention to it that may or may not make it succeed.
Some schools have done it where they've kind of minimized it. So in other words, a student can ask to come down to the nurse's unit and get their test done. You know, my boyfriend says he has such and such, you know, and then they get a test. And then we send our field staff in to do treatment. And then that person actually gets hooked up into health as well for further testing and services. Because that's your entree. That first positive test result, or even a negative test result, is your entree for that student. You thought you might have something, that's an entree to all the other health services that student, that young person probably needs. And it can be absence prevention education as well, or reproductive health education.
So Dauphin, Delaware, and Lancaster right now have active screening going on in the school. And it's all done not directly through the school, but through an outside organization that already had ties with the school and with that population. That's how that's working. We had one school district in the southeastern part of the state that was doing it completely as a school-based model, and they were getting very exceptionally high positivity. However, the board changed. There was one individual on the board that had an axe to grind against the program, and not only had the program terminated, but had staff that were associated with it terminated as well. So that's what I'm saying. You just have to be careful because the way the school boards are, it is what it is. But that positivity was exceptional. You couldn't deny they weren't finding the disease, but for one reason or another, unknown to what it was, they had issues and they had an axe to grind to make sure that the program stopped and anybody associated with the school was gone as well. So CBOs are definitely the way to go to the schools, an outside organization. Other questions? Okay, so the next steps. If you want to present this to your boards or whatever and they have many questions, then contact me. You have my business card. We'll come out and do a presentation to your board and answer questions one-on-one. If you don't have a board, or you are a representative of the board and you want to go to the next step, the next thing you need to do is complete this sheet and send it to us, and then we'll be contacting you to start that pilot program. After you demonstrate your positivity, we'll start working through getting a contract established. If there are organizations that are not here today that you know should have been here, please provide me their name, their number, and we'll come out and do a customized with that organization. Again, there's no right organization that we work with. It goes everything from school-based to faith-based and anything in between. So if there are organizations out there that should have been here that aren't, drop me a note by email, say that have them call me, and we'll do a one-on-one presentation with them directly. This is not a one-stop presentation. This is ongoing. We're going to be doing this for the next 5 years. So it's always going back and recycling in the community and saying, who else wasn't here? Who else can we outreach to? Who else can we contract with to do these services? And we're going to be doing this at least for the next 5 years. This is a big paradigm shift for the program and how we deliver services. So with that, lunch is provided. You guys can partake of that and then network with each other. We're going to be here to answer any questions that might come up and go from there. So again, thank you very much for having us.
Thank you.